My name is Fiona Duffy, so I'm a clinical psychologist who works in an intensive treatment service in CAMHS up in Lothian, which encompasses Edinburgh and surrounding areas. And this is Gavin Cullen, who's a senior charge nurse, who's in the same team as well. So what we're going to talk to you about today is the implementation of AMBIT within our service, the complexities of how that's gone, and we're going to focus. It's easier for us, if it's okay, to think about specific examples with regards to how we've used AMBIT. So we're going to specifically focus on eating disorders and how we've kind of integrated the use of AMBIT in our use of eating disorders. Our service is quite complex, I think it's fair to say. We've got, I'm quite proud to say, we know our population, 175,000 I think it is. And it's quite difficult, so unfortunately we missed some of the last presentations, so I'm not quite sure how our service might be aligned to the previous one, but I'll talk you through it. We cover 5 outpatient teams. And then we also have a number of specialist teams, which are, so these are tier 3 teams, sorry, and there are a number of specialist teams, including Edinburgh Connect, which is a service for looked after and accommodated children, a child sexual abuse service, a paediatric service, and our learning disabilities service as well. So these are what we call specialist teams. And then we have our tier 4 services, which include 2 day services for over 12s, a day service for under 12, our intensive treatment service, which we'll talk a little bit more about, and an early psychosis and support service. And finally we have an inpatient unit which covers Lothian, Borders and Fife within kind of Scotland. So there's 3 inpatient units in Scotland, and we'll cover one in the east of Scotland. With regards to the introduction of AMBIT, we were thinking quite carefully. Obviously we didn't have necessarily the funding to train everybody within our service, and we were also very aware that this was really deemed to be an outreach service for adolescents, so we kind of targeted specific people in our service to receive the training, which was really focused on our tier 4 services, specifically our early psychosis service, our day services, and our intensive treatment service. We had a couple of people from our inpatient unit who came along but didn't train the full inpatient unit, and a couple of people from our looked after and accommodated service and the child sexual abuse early intervention service, because we felt that AMBIT would be quite suited to them with regards to the complexity of services which they have to work with. The difficulties of this with regards to only training specific individuals is that what we found is that it created very much a shorthand language for those who had been trained. We talked an awful lot about things like having AMBIT moments or marking the task, and to our tier 3 colleagues who weren't used to this language, or sometimes our inpatient unit colleagues, this was just a foreign language really, which we were kind of immediately after training using quite regularly. We also didn't necessarily, especially with maybe some of our inpatient unit colleagues, or when we were sitting in another team meetings, have the same permission to mark the task. So I think it can be actually deemed to be quite rude if you don't have that shared understanding with regards to what you're actually doing when you're trying to mark a task. And so that was quite difficult, and also it was quite difficult for us to be able to recognise how important it was marking a task and then sitting in on teams who weren't doing it, and how frustrating that actually was for us as well. It was also difficult for other services to think in this way. So for example, tier 3 referral or an inpatient unit discharge was used to having huge packets of care, and it was quite difficult with regards to merging those 2 systems when we suddenly thought with regards to thinking about the key worker being central and pairing back the team, when an inpatient unit and our tier 3 colleagues were used to packages of care which were far bigger, involving far more professionals. And also differing levels of enthusiasm, and this is the reality with the model reflected in sign-up to training and integration into teams, with regards to actual attendance at the training in the first place, which then also created some difficulties within teams as well. We did as much as possible try and make it compulsory, I should say. We work in an intensive treatment service, which is a very small service, which was launched in April 2010, which is across Lothian, so it covers all of the teams which I've actually just previously discussed. It's a multidisciplinary service, and it's designed to meet the needs of young people with severe mental health difficulties through intensive community treatment. I think maybe we've got a slightly different protocol from the last service, because unfortunately it just came at the end, as I said. But ours is to prevent hospital admissions where possible, but also actually to facilitate appropriate admissions. We have a 12-bed generic unit, and we had a long length of stay. And what we saw very much as a goal of the service was to reduce the length of stay, which meant that we could have a higher turnover of young people admitted as and when required, and therefore reduce our admissions to adult psychiatric wards, which was a high priority for our service. So as a result, actually what we've done is significantly reduced the median length of stay. Our median length of stay is now 14 days in comparison to, I think it was well over 60 previously, wasn't it? So we've reduced our median length of stay hugely as a result of having an intensive treatment service which has the capacity to to care for young people in the community at a higher level of intensity than we've previously been able to. But we have managed to significantly reduce our admissions of young people to adult psychiatric wards by 65%, and we're now one of the lowest regions in Scotland with regards to adult psychiatric admissions. With regards to specific eating disorders, within our intensive treatment service, generally anorexia nervosa has a high presentation. It's about 30% of our presentations to the ITS. And we also targeted anorexia because we knew that although the numbers of admissions to inpatient units are not, well no actually there is a high number of young people with anorexia who are admitted to inpatient units, but it's more their length of stay, which is in comparison to other psychiatric disorders is long. And so we knew by targeting this particular disorder that hopefully we would see benefits with regards to reducing our length of stay. We also knew that anorexia is a highly emotive disorder as a consequence of both the medical complications, risk, morbidity associated with the disorder, and also the huge emotional impact of providing care for young people, both for parents and carers, but also actually for staff themselves with regards to an incredibly difficult job to manage young people with anorexia. It's also a disorder which tends to attract many professionals with different levels of service provision. So previously we would have things like dietitians, paediatricians, or psychiatrists, psychologists, a huge package of care, including perhaps day services, outpatient services, a variety of different services involved. And we know that this targeted the possibility of system disintegration and a lack of professional mentalisation. So we knew putting this all together that this was an area where crisis decisions could be made without kind of really being able to have the time to be able to mentalise both professionals and be able to have capacity to think through decisions. And finally, the implementation of the ITS really highlighted different practices across Lothian and in management. So we were very aware that within our outpatient teams there was a huge variety, and I don't think we would have been aware of this before until we had this service which covered all areas with regards to the treatment of young people with anorexia, even for example their medical management. With regards to, for example, one outpatient team had close links with our sick kids hospitals, so all the medical management was done via them, and another outpatient team it was done via GPs because they didn't have a treatment room within their outpatient team. So it was just highlighting difference in practices, I suppose. So we thought about various different AMBIT adaptations in terms of working with eating disorders. The first one which we did was to really think about the respect for evidence. We increasingly found that one of the main kind of evidence-based treatments for anorexia with children and young people is what's called FBT, family-based therapy, which is also called the Maudsley model. And we actually, while we provided systemic practice and also family work, we didn't actually provide this particular model within our service. So we recognised that there was a huge need to actually to train up numerous people within the service in this model, and have done so, which meant that we were meeting this respect for evidence. We also highlighted the respect for local practice and expertise. So we knew that actually within our service there was a huge amount of expertise actually already existing with regards to the management of anorexia, and we were really wanting to utilise this expertise to include really everybody with regards to there was an equity of care provided. So we did internal CAMHS training with people who were kind of more specialists with regards to working with eating disorders. And also just acknowledged that it was okay to have differences practiced across Lothian, but there had to be some common standards with regards to equity of care. And so we did this with regards to thinking about particular resource pack, integrating in things like medical management, using, gosh, I've got the marzipan guidelines, and just making sure, as I said, that while there may be differences in the practicalities, that the underlying care was equitable. We also focus very much on scaffolding relationships. I think prior to AMBIT, I would say that we as a service, parents would say to us that they felt as if we came in and took over. We came in as an intensive treatment service and supported meals, as opposed to actually supporting parents to be able to care for their child. And a lot of our parents and carers were saying that that's what they wanted. So instead, really what we focused on from an AMBIT perspective was actually providing families with the skills to care for their child, rather than us as a service go in and take over. And we also used a lot of the ongoing use of a parent support group to assist parents in this process as well. And then as much as possible with regards to intervening in multiple domains, we tried to cut back the number of professionals involved, and really think about instead the development of that individual key worker relationship, while encouraging key workers to be connected to the team. So very much focusing on our ITS CPN as being the main port of contact, but was supervised by the network and the multidisciplinary team surrounding them. And I would say that that was quite difficult for a number of professionals involved who were used to meeting their young person, and to provide a more consultation role was actually quite a difficult shift, I'd say, for quite a lot of professionals involved in our team. In terms of the impact of the changes, as a result of the significantly shorter length of stay in IPU, our overall admission rates have increased significantly. As I said earlier, though, we feel that this is positive because our goal, that was our goal, is to increase availability of the inpatient units to young people who actually need it at a point of crisis. But what's really interesting is that the admissions of young people with an eating disorder has gone against this trend. So every other psychiatric label, I suppose, within our inpatient unit admissions has increased because naturally our admission rates have increased, but actually eating disorders has reduced. So we had 19 admissions in 2011, it's now reduced to 10 in 2012. Also, analysis of our ITS admission and discharge has shown that our BMI scores have significantly increased with regards to effect sizes, and we also know from our CGAS and HANOSCA scores that quality of life is significantly improving for young people within our service. And also there's just an increased confidence across the whole of our CAMHS service about a pathway for young people with eating disorders, and really just increasing a more common language and a common use across the services, both in terms of treatment packages and hopefully getting the hang of AMBIT language as well. In terms of barriers, very quickly, we're not yet in the way, I'd say, of regularly manualising our work. And this was initially IT difficulties within NHS, an absolute nightmare. We have now got these fixed, but I think it's just really, we've noticed it. We've had a couple of CPNs who've left recently, and it's the realisation that their experience has gone with them, and actually we really need to get used to actually manualising far more frequently. Also, despite having AMBIT leads who were really our champions with regards to encouraging AMBIT practice, it wasn't really clear what the role was, and there hadn't really been management buy-in to that group, but more recently we've been able to do that and have a stronger presence. And also the number of transitions that these young people experience, and Gavin's going to go on and talk about this a little bit more, alongside the high levels of risk, means that we're constantly working to prevent kind of system disintegration. It's actually a reality that this is going to happen, but we just know that we need to constantly work on it. And then the fast pace and crisis-driven nature means that it is sometimes difficult to actively plan in a thoughtful way, especially at things like times we've had reduced staffing, which makes it even more difficult, and I think we just have to have an awareness of that.